Jayashri Kulkarni is a professor of psychiatry and the director of Monash Alfred Psychiatry Research Centre. She is internationally recognised for her expertise in the treatment of mental illness, particularly in women's mental health. She has pioneered the use of estrogen as a treatment in schizophrenia and has developed many other innovative treatments for mental illnesses. Jayashri is a passionate advocate of patient-focused mental health research and a regular media commentator on mental health-related issues. With more than a third of mental illness sufferers not responsive to current treatments, she believes there is an urgent need for investment in clinical psychiatry research so that new and effective treatments for mental illness can be developed. Over to you.
So I'm going to be speaking on women's mental health, and I have, as always, probably given you far too much, and we'll skip through bits and pieces as we need to. So why women's mental health? Well, we still have the issue where medicine generally assumes that the archetypal patient is male. And this is particularly reflected in things like medication doses, which are still a one-size-fits-all type of framework. But we do know that women actually constitute the greatest percentage of patients who require treatment for depression, anxiety in particular, but other mental illnesses as well. And we also know that still today women do have the major role in caring for both children and older parents, and therefore can have aspects of burden of care type conditions as well. There are differences in liver enzymes, neuroendocrine interactions. Psychiatric illnesses can obviously differ in men and women because of the gender differences in the social responsibilities and the expectations. And, you know, the really obvious stuff is that, you know, certain illnesses are only ever seen in women, such as postnatal disorders. I will be speaking a little bit later about this, about diagnostic methods and labels, and in particular about borderline personality disorder, which I think is a particularly awful label, but we'll go into that in a bit more detail. So for all these reasons, it's really important that if we're going to have advances and breakthroughs and we continue to provide the best quality care for our patients, that we start to think of the gender aspects of the person in front of us. That it is not appropriate to consider that whatever the treatment for schizophrenia is, it will be exactly the same and effective the same in both men and women. Certainly in research, to conduct such things as imaging research, or in my area, psychoneuroendocrinology, the gender of the patient is actually the driver of the type of research that we conduct. Using biological sex bases is often a very clear way to look at population results. So again, when you pick up the latest findings in certain, say, genes research or whatever else, it is important to see whether the researchers have actually considered the gender of the patient, because sometimes that doesn't actually happen, and it does throw a question mark on the results. So today I'm going to talk about what we call complex trauma disorder, aka borderline personality disorder. I want to talk about pregnancy medication management, women and schizophrenia, menopause mental health, PCOS, polycystic ovarian syndrome and mental disorders, and management of depression in women. We may not get through all of it, but I'll give it a good shot. So obviously with the rest of Australia at the moment, there's a considerable amount of awareness raising that's going on about the level of violence in Victoria and in Australia. Violence against women in many, many different quarters. Male intimate partner violence is something that we worry about extensively in terms of being the leading contributor to death, disability and illness for women aged 15 to 44 years. This is Vic Health data. I know that's the 2004 data, but their recent 2014 data actually is worse in terms of the increasing violence against women. So this is a big issue for us, all of us in the mental health field, as well as obviously the community. So The further data from the personal safety surveys, in fact, are even grimmer. They do actually talk about the fact that well over 1/3 of women have had physical or sexual violence. That's 1/3 of the female population. That's a considerable number of women who experience violence against them. So I won't go through all the figures, but you're very much aware of this particular issue. What is worrying me somewhat is that while it is good that there's public debate about this, there is conscious raising awareness, there are some very high profile and horrible tragedies involving violence against women. Rosie Batty, as Australian of the Year, has made her own personal story quite public. The difficulties become that we're not hearing the penetration into the mental health issues as a result of the violence. So we're doing some work at the moment trying to provide toolkits for general practitioners. Because general practitioners as the primary care providers are often the ones that are in the driver's seat in terms of the battered women, etc., coming to see them. And what we've discovered from our various surveys of general practitioners in 2 different catchment areas, in the Knox area as well as around the Alfred, is there's great sense of overwhelming a feeling of just, I don't know what to do. As one GP said, I don't ask anymore because if I get the answer that she is having violence at home, I don't know what to do about it. And I really have a waiting room full of people that I need to get through, and I just haven't got the tools to actually take the history and know what to do with it. And then he sort of hastened to add that if there's a fractured arm, of course it makes it all that much easier. But in terms of the long run-up of violence, which has mental health effects, we really are not touching the surface in that. So again, we do have the issue of the many effects of trauma, and you will have seen this in a number of your patients, the depression, anxiety, brief reactive psychosis, and this condition that I'd like to describe a bit more, complex trauma disorder. I think the term DSM, that DSM-5 uses and other DSM have used, borderline personality disorder, is a particularly horrible term. When you discuss this with your patients, I don't know what experiences you have, but in the past, the experiences have been, what do you mean borderline? Does it mean I have something or I don't have something? And personality disorder is a pejorative term, not just to the patient, but it carries with it an enormous amount of stigma in our psychiatric systems and in the general public. And it seems to be the sort of thing that, well, hang on, you're attacking that which is deeply part of me, my personality, and you're telling me that that's stuffed. It's not good. So this gets equated with bad, and we all know about the stories of borderline patients who have got chronic conditions and the various treatments that are given to them. I had to say my heart sank a couple of weeks ago when I got a call from a registrar, a female registrar. I mentor certain female registrars and female students as well, an informal network. And she rang me in tears from a public hospital ED to say that she got down to the ED to see a woman who had lacerated her own wrists, and the charge nurse had instructed the intern to suture the laceration without an anaesthetic, saying this would teach the patient not to do it again. So by the time the registrar got there, she's having to contend with all of this. And this is 2 weeks ago. So if we think we've moved out of the era of stigma against our patients, this is a group of patients who do elicit a strong stigma and appalling reactions. So I think part of it is actually is in the name. It's like, what's in a name? Well, there is a lot in the name. So Satya Rao and a couple of us trying to think about if we can get this turned around. I was on the working party, the DSM-5 working party for borderline personality disorder, and I kept pushing for the sense of complex trauma disorder, but I got thrown off the working party because I was actually too troublesome. But the reason that the DSM-5 continued to make that distinction is because they said trauma is the province of the war veterans, and you cannot muddy that condition by involving all these women in that condition. That is something that we hold very importantly as a sort of badge of honour for the war veterans. So these are the sorts of things that worldwide we're actually trying to face. But and I don't need to go through the symptoms of BPD, CTD, that these are deep feelings of insecurity, fears of abandonment, loss, of inappropriate anger, fragile sense of self, and dissociation. Persistent impulsiveness, the confused, contradictory feelings, and the self-harm. So for us in psychiatry, we've got a pretty good grasp on what constitutes this condition. But try teaching this to medical students or to other people that are not immersed in psychiatry. It is a very vague condition. There's a collection of symptoms, and then you've got overlying that episodic depression, episodic mania, this term bipolar 2, which keeps popping up all the time. And again, Phil Mitchell in Sydney from the Black Dog wrote a particularly good paper about how many times the diagnosis of bipolar 2 is actually masquerading and is a cover-up of borderline personality disorder. But the difficulty is that patients accept bipolar 2 much more readily than a stupid term like borderline personality disorder. So you kind of get caught in this trap. The difficulty, of course, is once somebody has a label of bipolar 2, they go down the 2 or 3 mood stabilisers plus 2 or 3 antidepressants plus some anxiolytics, and the whole prescribing area is quite messy. Clearly, obviously, there is overlap with a number of conditions, and I often refer to borderline personality disorder or complex trauma disorder as the blob. Remember that old science fiction movie where you had this blob that just absorbed everything in its pathway? I think this is the condition that absorbs every other condition in its path. I think we're actually sitting on the threshold of an epidemic of borderline or complex trauma disorder. It is a complex disorder, it's often misunderstood, but of course what we're seeing in emerging adolescents and even younger than adolescents in girls is this increasing self-harm, increasing low self-esteem, increasing anger and rejection. One of the issues with the youth mental health services is that they do a great job with youth, but the definition of youth somehow seems to have become that of the young man who might have a whole lot of substance abuse issues and have forensic issues or delinquency and so on. Youth is actually also young women, and the angry, self-harming young woman isn't usually the poster girl for youth mental health services. So, and also is not the patient that people really do take on, and is not lovable a lot of the time and therefore difficult to help. But we need to think about what is happening here. I have a second opinion women's mental health clinic at the Alfred, and I have to say that we are seeing an increasing number of 13 and 14-year-olds who are presenting with issues that are looking like incipient or emerging borderline behaviours. And really the abandonment, the self-harm, the poor identity, the rage as the key features seem to be the main issues. Clearly we do know about the abuse stories, and this ties in with the violence situation that we're seeing in our community, that as the violence is increasing, we're seeing increasing abuse, sexual, physical and emotional abuse, with ongoing stress as a background, causing the biological, psychological changes, leading to the condition that I will call complex trauma disorder, but it's also known as borderline, which then leads to the self-harm, the rage, the relationship and the work issue. So we've got this spiral going on, and I personally think that we're seeing this spiral at a younger age. I know, Izzy, you're an adolescent psychiatrist, and I wonder what the other child and adolescent colleagues here are seeing as well. I'd be keen to get your opinion, but it certainly does bother me that we're seeing 9-year-olds with increasing social disturbance in their actual family milieu. The single mother with a lot of substance abuse going on, different males in the household and the boundaries not being observed, and so we have emotional and then also sexual abuse. I think we're also looking at a graded impact of abuse on mental health. So with emotional deprivation and emotional abuse, we're seeing a sort of slightly lesser version, with some of the symptoms being the identity difficulties, the disturbance in self-esteem and rage, but then moving through the spectrum to the worst end, which is the sexual abuse, where we see the full complement of all of the borderline type symptoms. The biology of borderline is poorly researched, and it's an area that we hope there'll be a lot more investment in. But we do know something about the fact that with early or consistent ongoing emotional deprivation or abuse, there is a rapid rise of cortisol, and this activates the HPA axis. What does cortisol do in the brain? This is an old study, but if you have a look at the study, basically it's showing that, and this was with actually administering cortisol, the higher the dose of cortisol that's administered, the worse the verbal memory performance and in fact cognitive performance in general. So these girls, and it does happen to boys as well, but is predominantly in girls, these girls whose households are very stressful and there's an ever-present threat of abuse of some sort, will live with this very high elevated cortisol levels and HPA axis activity that has a feedback onto a number of other systems, including the actual CNS. And in terms of verbal memory performance or other executive performance, it is quite poor. So many of my patients will say things like, I don't remember. There are big chunks of childhood that are just missing. Again, we can hypothesize in a psychodynamic term that that's kind of protective, that the horrible stress is blocked out. But there's also a actual neurocircuitry aspect to this. And it makes new learning very difficult. So these are kids who then, of course, don't do well at school and can't kind of educate themselves out of an awful social circumstance. In women, as I said, the stress impacts on the cortisol, but girls with sexual abuse history often present later with borderline personality disorder, and those symptoms are, again, in a variety of the spectrum. There is also noted higher sensitivity to later stresses. So somebody who's had this kind of abusive background early in life is much more sensitive to any stresses perceived and otherwise later on in life. We also know that girls actually have the HPA axis is actually a little bit more, if you like, sensitive in women, and the highest cortisol levels actually occur with the highest levels of sexual abuse and emotional abuse. And we also know that social rejection is something that causes high cortisol levels as well. So the stresses can be of many different types. The other thing is, as I mentioned, once you get a cascade phenomenon in one of the gonadal axis, one of the HPA axis, it has an impact on the HPG axis as well. So this is where cortisol impacts fertility in women, and weight gain is much more prominent. There is also thought to be related sex hormone binding globulin differences. So you can see that there's quite a feedback loop that's going on between the cortisol and the ACTH, and then other branches of the parasympathetic and sympathetic systems. This is where the PCOS story comes into it. So again, we're seeing a lot of girls and young women who have had emotional deprivation, emotional abuse, or physical abuse, or sexual abuse, who seem to end up with both physical and mental ill health. And the depression that we know is associated with coronary artery calcification, so that's another complication. We have high rates of ischemic heart disease in this group, but we also have high rates of obesity and also polycystic ovarian syndrome, which has got its attendant diabetes, and infertility, hirsutism, and PCOS also has an impact on antidepressant and antipsychotic drug metabolism. So it's a complex interrelationship where we're now having to look at these young women, and you've seen them. The stereotypical picture is the very angry, overweight woman who has facial hair, who looks masculine, and is often the woman who is turned away from the emergency departments, etc., the classic frequent flyer. In terms of our treatment here, we now have to look at a combined sort of effort in biology as well as obviously in the psychology, and then looking at the family networks in terms of treating her PCOS, which results with or causes increased testosterone. So it's a feedback loop. You get increased testosterone, then you get further increased testosterone, which then causes further ovarian cyst formation, and then that particular hormone imbalance leads to increased rage and infertility, obesity and diabetes. So you now have this very intimate link between abuse and all of these physical parameters, plus also the rage, the self-harm, the self-identity that's disturbed, the fears of abandonment, and those difficulties leading to problems in relationships and work. Is this the picture of patients that is familiar to most practitioners here? Yeah. So again, we do advocate in these instances that we need, the title was biopsychosocial approach, and I know that's a hackneyed catchphrase, but this is the group of patients who exemplifies this. Because if we don't actually pay attention to what is going on in an endocrine sense for these women, and they're young women, then we actually keep making the whole other circuit, psychological and social problems worse for her as well. And we will impact adversely on drug metabolism if we don't deal with the PCOS. We are seeing a hell of a lot of PCOS, and it's far more than it was. And we think that, again, it's because of this increasing levels of trauma in amongst the 9 to 13 year age group, with resultant traumas and so on, with resultant endocrine dysfunction. How do you treat PCOS? Usually with estrogen supplementation, but metformin, which is an anti-diabetic drug, which is also used for diabetes prevention. It is also used for weight loss, and aldosterone. So the commonest form of estrogen supplementation in this age group would be the pill. So a combination pill. And we tend to like Zoli as our favourite pill because it has a better type of progesterone that doesn't seem to cause the same level of depression as some of the other progesterones. So Zoli is Z-O-E-L-Y, and some of the other pills, and I'll come to our pill study in a minute, some of the other pills are associated with depression, particularly the ones that have medroxyprogesterone or norethistérone as the progesterone component. Again, staying with this condition, fMRIs do show significant sex difference in brain activity and stress response circuitry across the menstrual cycle. So this again is evidence that hormone regulation is important in stress management. So again, making my case that when we've got somebody who has this set of conditions, please look at managing the entire patient in terms of biology as well as the psychology.